morning. My name is Joanna Rymuza. I am from the Department of Internal Medicine and Endocrinology in Warsaw, Poland. And today I am very pleased to present a case involving coexistence of central diabetes insipidus and cerebral salt wasting syndrome. Our patient is a 38-year-old woman who had a complex medical history. She was after numerous neurosurgeries due to recurrent chordomas within her central nervous system. After the last neurointervention involving the resection of a tumor adjacent to the third ventricle, she was treated for hypopituitarism. Upon the admission to our department, she experienced increasing fatigue, cough, and confusion. Physical examination revealed hypotension, hypoxia, and crackles indicative of bilateral pneumonia, which was confirmed by chest CT. Immediately, we started oxygen therapy, ceftriaxone. We switched oral hydrocortisone into intravenous. And we observed gradual improvement of patient's condition and inflammatory markers. However, on the third day of the hospitalization, hypernatremia emerged, and the patient's urine was diluted, and it was polyuric. Given the history of hypopituitarism, the initial diagnosis of central diabetes insipidus seemed quite obvious. Therefore, we started desmopressin, yielding initial improvement in serum sodium level. Yet on 7th day, the hyponatremia emerged. We were wondering why. Initially, we thought that maybe the dosage of desmopressin might have been too high, so we reduced it. Unfortunately, the serum sodium level kept falling. Then we thought that maybe that's a case of a biphasic phenomenon in which after the polyuric phase comes the antidiuretic phase, which is caused by the unregulated release of antidiuretic hormone from the posterior pituitary lobe. But if that would be the case, I would probably not be standing here today. So we withdrew the desmopressin and we observed increase in the urine, polyuria again, and what brought our attention was the concentration of sodium in the urine. It was very high. So we thought that maybe the patient had another cause of hyponatremia. We suspected coincidence of central diabetes insipidus and cerebral salt wasting syndrome. We restarted desmopressin in a patient with hyponatremia. We gave fludrocortisone to support aldosterone action. We gave hypertonic saline for correction of natremia and physiological saline for correction of volemia. And the patient was better. Her condition improved. Serum sodium level normalized, and she went home on her own feet on desmopressin and fludrocortisone. Cerebral salt wasting syndrome is a rare cause of hyponatremia. It occurs in patients with intracranial pathology. According to one of the theories, natriuretic peptides block the action of aldosterone, impairing the reabsorption of sodium from the urine, which leads to natriuresis, polyuria, hypovolemia, and hyponatremia. Distinguishing this syndrome from the more common cause of hyponatremia, namely the inadequate secretion of antidiuretic hormone, can be challenging. But presence of natriuresis, polyuria, hypovolemia, and hyponatremia is more typical for cerebral salt wasting syndrome. To sum up, I would like to underline that sodium balance disorders are prevalent in patients with intracranial pathology, warranting consideration of multiple etiologies: central diabetes insipidus, inappropriate antidiuretic hormone secretion, cerebral salt wasting syndrome, and sometimes, in rare cases, the coexistence of these etiologies is possible. Thank you very much for your attention.
Hands up whoever considers low sodium as a difficult clinical situation. Okay, well, congratulations of attacking it. I just want to congratulate you on day 14 of hospitalization. The patient had the same sodium as on day 1. But the roller coaster was impressive. It's
That's
amazing you figured it out. Professor Preptani, any comments here?
Vasopressin deficiency. We're not using diabetes insipidus anymore. We're using vasopressin deficiency.
Yes.
Because people were making errors between diabetes mellitus and diabetes insipidus. That's just a comment. Some people don't believe in CSW. I do. I think there's enough literature and clinical experience that it is probably a real entity. My question is, often CSW or cerebral salt wasting is often transient, and we often see it in the setting of a subarachnoid hemorrhage, unlikely pituitary disease or cellular mass resection. Was a trial follow-up done later on to see if we can stop the CSW therapy, the high sodium, the the high sodium intake, etc., and the fludrocortisone to see if there's been recovery?
Thank you for this question. I do agree that according to the literature, the cerebral salt wasting syndrome is transient. Actually, in our patient, it was long-standing. She had progression of her neoplastic disease. She had another tumors within her central nervous system, and we suppose that that was the reason why it was long-lasting. We followed this patient and we checked it. We even tried to withdraw some drugs. We tried to withdraw actually even desmopressin for a moment, but it was impossible. The patient always needed both drugs. That's the answer, I think.
And one other question that was a great reply is that, like you said, is sometimes it can be difficult to differentiate between SIAD and CSW, and one of the manifestations is significant hypovolemia in CSW. What were the hemodynamic parameters in this patient when you made the diagnosis of CSW, the blood pressure?
Yes. We noticed that was the moment when the natremia was the lowest. Then she had tachycardia, she had low blood pressure, I have to say one more thing. When it comes to this patient, the patient was after the surgery next to the third ventricle. She had troubles with fist, with eager to drink. So managing the adequate fluid dosage in this patient was very, very difficult. So we tried to avoid this hypovolemia, giving her intravenous fluids, but it was very difficult. So that were the symptoms of the patient.
Thank you for a very rare presentation of a common condition.
The last question.
Yeah, thank you for this nice presentation. Patient is polyuric. So sometimes challenge to make interpretation of urine sodium. So maybe I missed the slide. How much urine sodium?
Urine sodium, it was 180 millimoles per liter.
Okay.
It was very high.
Inappropriately high. Okay, well, thank you very much for very challenging case.
Thank you.